Hi everyone. I'm going to be presenting on amyotrophic lateral sclerosis, or ALS. Um, some of you may also know it as Lou Gehrig's disease. So what is ALS? ALS is a motor neuron disease affecting only somatic motor neurons from the peripheral nervous system. Both the upper motor neurons and the lower motor neurons degenerate or die and stop sending messages to the muscles. Unable to function, the muscles gradually weaken and start to twitch and waste away. The etiology for ALS is somewhat unclear. There are familial cases and sporadic cases. So the familial cases are less common, and those are based on genetic factors. And the sporadic cases, researchers believe that they are due to potentially glutamate insufficiency, metal toxicity, autoimmune factors, other genetic factors besides a family member having been diagnosed previously with ALS, and also viral infections. So ALS is a progressive disorder, and it's a rapidly progressing disorder. Death usually occurs for patients diagnosed within 3 to 5 years, and only 10% of people survive for 10 or more years after their diagnosis. Most deaths with ALS are actually due to respiratory failure. Some signs and symptoms of ALS. So typically weakness begins to present in the hands and the feet and then the limbs. There's slurred speech, trouble swallowing, muscle cramps, twitching in the arms, shoulders, and tongue, decreased postural control, difficulty walking, and decreased participation in ADLs. When we're documenting, or if we're reading documentation from a client with ALS, a lot of the terms for the signs and symptoms that we might be seeing include paresis, myoplasticity, hyperreflexia, Babinski's sign, atrophy, fasciculations, and fibrillations. So diagnosing ALS is actually very, very difficult to do within the first year because many of the signs and symptoms mimic signs and symptoms of other neurological disorders and conditions. So ALS is actually diagnosed by ruling out other neurological disorders, looking at the clinical symptoms. Tests that can be done include EMGs and nerve conduction velocity studies, blood and urine studies, spinal taps, radiographs, MRI, and muscle biopsy. Again, I want to point out that with the rapid progression of ALS, it is important to diagnose as soon as possible in order to be able to provide whatever medications and whatever kind of therapy we can so that they can live their life to the fullest with their diagnosis. For risk factors, ALS is commonly diagnosed between the ages of 55 and 75. It's more commonly seen in men versus women, and also Caucasians and non-Hispanics are more likely to be diagnosed with ALS. Research shows that military veterans are actually 1.5 or 2 times more likely, and this is due to the exposure of lead, pesticides, and other environmental toxins. So about 90% of ALS cases are sporadic, and about 5 to 10% are familial. And out of the familial cases, 25 to 40% have a defect in chromosome 9 open reading frame, which I will discuss again later, and 12 to 20% show a mutation in gene producing enzyme copper zinc superoxide dismutase. So, neurological impairments related to ALS. We have progressive bulbar palsy, which is a bulbar form, and it involves the cortical bulbar tracts and brainstem nuclei. Symptoms include dysarthria, dysphagia, facial and tongue weakness, and overall atrophy. There's also the progressive spinal muscular atrophy, which involves lower motor neurons in the spinal cord, and sometimes there's brainstem involvement. Symptoms of this include atrophy of limbs and the trunk, which would show as decreased postural control. Primary lateral sclerosis involves the upper motor neurons and the destruction of cortical motor neurons, corticospinal and corticobulbar regions. This would present as progressive spastic paraparesis. Now, frontotemporal dementia. The presence of C9orf72 is the chromosome that I mentioned previously being responsible for the more cases of familial ALS. And this repeat expansion in patients shows an increased risk of developing either frontotemporal dementia or ALS or combined both diseases. The FDA has approved of some drugs in order to medically manage some of the signs and symptoms of ALS. Riluzole or Rilutec decreases levels of glutamate. Edaravone or Radicava slows the decline in clinical assessment of daily functioning for these patients. There's medications for pain, depression, and sleep, both over the counter and prescribed, because due to the symptoms and the progression of the disorder and the disease, the patient will experience pain. There's a psychosocial component to it, and sleep will be affected as well. As the disorder progresses, the patient may need a ventilator or a feeding tube, and scientists are beginning to really look into stem cell research and have developed ways to actually take skin or blood cells from individuals with ALS and turn them into stem cells, which are then capable of becoming any cell type in the body, including motor neurons and other cell types that may be involved in the disease. For the OT evaluation, we want to start with the occupational profile, which can be done formally or through an interview informally. And I think it's important that we involve the caregiver and or family members, as this is such a rapidly progressing disease. The client is going to need to have assistance at home. So really getting an understanding of what their understanding is of the diagnosis, what their goals are, and setting realistic expectations. So using the COPAM, we can actually use the COPAM to assist a person with Parkinson's disease and other neurological disorders to identify those daily tasks that he or she wants to do, needs to do, or is expected to do, but cannot, or that are not performed to a satisfactory level for the individual. This approach presents the unique concerns of OT, thus ensuring efficiency and promoting increased effectiveness of OT intervention with patients, and also captures the unique domain focus of OT. Another assessment that we can consider using with clients who are diagnosed with ALS is the Performance Assessment of Self-Care Skills, otherwise known as the PASS. And the PASS has four domains broken up into functional mobility, ADLs, and IADLs. And IADLs are looked at both cognitively and physically. It is a performance-based and client-centered assessment and has high test, retest reliability and inter-rater agreement. The areas of occupation impaired from the OTPF, we really have to look at every single area. The signs and symptoms will begin showing as maybe some general weakness, some atrophy in distal extremities, and it eventually will move from distal to proximal. So at first, we may be looking at things like providing some adaptations and compensatory strategies for feeding if the individual is having some weakness in their limbs. Eventually, with the progression of the disease with feeding, we're going to be looking at a feeding tube. The pain and other signs and symptoms associated with ALS will most definitely affect work, play, leisure, and social participation, and definitely sleep. So we want to make sure that we're really taking a holistic approach to therapy with these clients. Finally, for the models of practice and frames of reference, I think that it's important that we take as much as we can from models and frames. So the first frame of reference that I looked at was the psychodynamic frame of reference because of the psychodynamic involvement with this disease. And it breaks the frame of reference into 5 different categories for us to consider during intervention. These 5 categories are social participation and relationships, emotional expression and motivation, self-awareness, defense mechanisms, projective arts, and activities. Also, the occupational adaptation model. This is an interactive process between a person and his or her occupational environment, and it can be applied across the developmental lifespan with a holistic application to a variety of populations and therapeutic needs. And last, the model of human occupation has a focus on engagement in occupational behaviors that maintain, restore, reorganize, or develop their capacities, motives, and lifestyles. And really thinking that through participation in therapeutic occupations, our clients can transform themselves into more adaptive and healthy beings. Here are my references. Feel free to reach out with any questions and comments, and I look forward to hearing from you. Thanks.